Welcome everyone to today's webinar. We'll be covering safety netting in primary care, and I'm joined by the two presenters. So first we've got Dr. Anthony Cunliffe, Joint Clinical Chair of South East London Cancer Alliance, Joint National Lead Macmillan GP Advisor and Macmillan GP Advisor for London. And then we've got Sue McNulty, Facilitator Manager for the South and North West London of Cancer Research UK. So I'm just going to go over a couple of housekeeping rules and just touch around the evaluation form. So all viewers are muted and your cameras are turned off by default, just to ensure that clear communications and privacy. If you have any questions, please click the Q&A button, which is at the bottom of your screen. If you'd like to discuss anything with audio or video, please indicate this when you're asking your questions, We'll cover questions either during the relevant presentation or after the speaker has finished. If you have any technical issues, please let us know via the Q&A button or via email. And finally, this presentation will be recorded. We just like to ask at the end of the webinar that you complete our online evaluation form. So this will help us with planning any future events. So we'll use that feedback. This will appear when you close the Zoom window, and also it will be sent via Eventbrite straight after the webinar has closed. And then once you've completed the evaluation form, you can download a certificate of attendance. I'm going to hand over to the panelists now to start with our webinar on safety netting.
Hi everyone, thanks for joining today. I think we've got a really good number today, and I'm really pleased because I think it's a really important subject we're covering today, and hopefully you'll go away having learned some things and having some clarity about maybe how you can change things, the way you form safety netting in your practice or your PCNs going forward. So we're going to start with a few slides on general safety netting, then we're going to have a little bit of a focus on cancer and why it's important for cancer. Talk a little bit about the QoF QI and the PCN spec, the DES for the PCNs, and why safety netting is an important element of them and what you need to do to achieve the safety netting element of those. Then I'm going to hand over to Sue, who's going to present some South East London data and safety netting, which is really interesting. And then we'll talk a little bit about some IT forms of safety netting that you hopefully will want to implement in your practice. And we'll stop for questions as we go along, but also we'll have a chance for questions at the end as well. But what is safety netting? I'm sure certainly any GPs that are watching will remember learning about Roger Neighbour when we did our GP training, and he introduced the concept of safety netting in general practice really, and he considered it a core component of the consultation. He defined it as encompassing three main questions. So if I'm right, if I've made this decision or if I have a diagnosis or about an action to take, and I'm right, what do I expect to happen? How will I know if I'm wrong? And what would I then do to remedy that? Now, over the years, safety netting, thinking about safety netting and the understanding of what safety netting is has changed a little bit. And I think for many now, it's broadened and very much represents or incorporates proactive follow-up, which is slightly different. But I think when most of us think about safety netting, we think about it all in one. So it really is a strategy to help manage diagnostic uncertainty and help make sure that if we've got patients that we've referred for investigations or that have presented with symptoms that might represent serious disease are followed up in a timely fashion and in an appropriate fashion. As GPs, we all know that we see a huge number of patients and many patients every day with symptoms that may or may not represent serious disease. And we need to have safe ways to monitor these, both those that we don't immediately follow up, don't immediately investigate, and we want to follow them up, and those that we do investigate, and we need to make sure that we follow up the results of the investigations. It's also a really important way that we ensure that people who are needing planned follow-up, so which is a repeat test X-ray, regular follow-up tests such as a PSA, to make sure that they don't fall through the net and that we can be confident that people are getting these investigations that are planned. From a medical legal point of view, it can certainly help protect the doctor, and it can obviously, for clinical reasons, it can help protect the patient. So we're going to talk about two of the main elements of safety netting now that I've already referred to, so the consultation and then proactive follow-up. So a lot of the safety netting that we do is part of that consultation. So it's, obviously it's really clear that good communication is core to being a safe doctor, and it's a vital element of how we safety net patients. It's really important that we are specific with our advice and we're explicit about any timelines that we plan for follow-up. So we hear quite often that we tell patients to come back if the symptoms don't go away. And patients don't necessarily really hear that, and they certainly don't know quite how to act on that. So it's really important that we are clear that we genuinely mean that we want them to come back if their symptoms don't go away. And one way of doing this is being very explicit around timelines. So being, clearly saying to them, if your symptoms haven't gone in 2 weeks or 4 weeks, I really want you to recontact. One way that we can be sure that we've been specific about our advice is checking a patient's understanding. We all got taught to ask a patient to repeat back what their understanding was, and we don't necessarily always do that, but just making sure that a patient has had a clear understanding so that we can be sure we've explained things clearly. Information giving is vital, so written information is vital and can be a really important way that we can be confident that we've safety netted. So examples might be, we should make sure that everybody on an urgent suspected cancer referral receives a patient information leaflet explaining to them what that referral is about. We might give them this in their hand, as when we do the referral. We might ask admin to do that, and more now we're using digital methods to do that, such as sending people an information leaflet via an IQRX, sending people these or emailing it to them. Another element might be, and this is a non-cancer element, but sometimes giving people written information on a potential diagnosis with giving them an asking them to go away and read that. I often do this, and because if I'm uncertain about a diagnosis, I find it really useful to give a patient written information and empower them to then come back to me and say, what, I read that information and I think you're right. I think that's what my problem is. But then it can empower them that if they're not confident that your diagnosis is correct and you've given them that information, giving them the permission to come back and say, actually, I've read through and maybe I didn't communicate well, or maybe there was a misunderstanding, but I don't think that's what's wrong. And safety netting can take forms like that as well. The MDU will definitely say, and GMC will definitely say, document the specific advice given. So don't write given advice or advice given to the patient. Document the advice you've given them. So if you've asked them to come back in 2 weeks, or if the symptoms don't go away, document that very specifically. A lot of us are part-time, so let's make sure that a patient understands that they might not necessarily have to wait for us to come back in if they have ongoing concerns, and make sure that they know other ways that they can seek help. I'm going to just talk a little bit about proactive follow-up now. So this is a really important element of safety netting, and maybe for a lot of people, this is what they see as safety netting in our day-to-day practice. The GMC advice is that we should consider making a follow-up appointment ourselves. Now, we appreciate all our practices work differently, and it's not always feasible to make follow-up appointments in the future, but GMC certainly says that if you make a follow-up appointment, then we'll be really conscious if somebody hasn't turned up, and then we can actively follow them up after that if we feel it's necessary. Proactive follow-up does not have to be the GP's job. It can involve the whole practice team, and admin can often lead on this, and we'll certainly refer to that when we talk a little bit later about the IT systems we can use to follow people up. I think more and more now it's understood that having a robust IT system the way we can structure our proactive follow-up can be invaluable. And these might be things like diary entries or adding alerts, or we'll talk about a couple of specific tools that are available later in the presentation. And we might need to agree as a whole team whose responsibility it is. What system are we using? What system are we using in what situations? And whose responsibility is it to follow up and check people have been seen? So just a few slides now, specifically on safety netting for cancer. In the NICE guidelines that came out in 2015 for urgent suspected cancer, they were explicit about the importance of safety netting in there, and they gave some specific advice. So 3 elements that they pointed out that we should ensure that the results of investigations are reviewed and acted on by the person who ordered the test, or of course sometimes we need to hand this over. And through some studies, some situations have been highlighted why it's really important that we do follow up on tests ourselves in some certain situations. And this fits into the next bullet point about false negatives. So examples that have arisen are often things like urine tests. So somebody may have presented with hematuria, and we send off an MSU to make sure they've not got a urine infection, as NICE tells us to, before we consider a referral. But then often, if an MSU comes back as normal and we're not necessarily following up ourselves, or we've not safety netted, that result will get filed as normal. And then we've got a patient who's had hematuria, had a negative MSU, and that person, if they meet the age criteria, should be having a 2-week rule referral. But it's very easy for that to get missed unless we're proactively following that patient up who's had a negative result. Similarly, potentially with prostate specific antigens, so with PSA results, people who've had a radical prostatectomy should expect an absolute, less than 0.01 PSA result. Often these can be risen still very much within the normal range, but unless that person's been explicitly followed up, that file can be filed as normal when actually for that patient it isn't normal. So just having these really clear plans of how we follow up investigations. Be aware that there are other investigations that can be falsely negative. So a normal chest X-ray, we know that over a quarter of chest X-rays in people with lung cancer can be reported as normal. So make sure that we are following people up if we're concerned, despite normal tests. Thinking about those low risk but not no risk patients, so people who presented with symptoms, perhaps vague symptoms, they don't meet those 2-week rule criteria, but we're still concerned that perhaps the symptoms do need following up. So be specific about timeframes with the patient and use IT systems to make sure these people are followed up so that we can be comfortable, because sometimes you might want to leave a patient, a few weeks before they necessarily need to be followed up with some symptoms. And so we need systems so that those people don't fall through the net. And Sarah. So examples of safety netting for cancer. So certainly patients on a 2-week rule referral rate, we should have very clear systems in place to make sure that we know if these people have been seen and then followed up if they haven't been seen. We must think about direct access diagnostics. So some GPs have access to a lot of direct diagnostics and some of us don't have access to as many, but when we're using these tests, so examples there are FIT or chest X-ray, but obviously it does ultrasound for some GPs, it will be CT. Make sure that we have a clear way in place, system in place to follow these people up, to make sure results are reviewed, and then the appropriate action is taken, either if that result was abnormal, because if we request a direct access diagnostic, the responsibility for following up on a result does fall with us as a GP. But also, as we've said, sometimes even a normal result, the patient might still need following up. Vague symptoms, well, we're not sure about a diagnosis, but we have concern. These a lot of these patients, we will need really clear systems in place to, whether that's in our communication with the patient about when we might want them to re-present if symptoms don't go away, or proactively if we want to be contacting them ourselves. Patients who have negative reassuring results, I think we've perhaps covered that, but we might see patients and do some tests and the results might be normal, but the patient's got ongoing symptoms, and it's really important that we should always be clear to a patient that negative results don't mean that there isn't an underlying serious illness, and that we need to be clear in our communication there, but also potentially have systems in place so that we can proactively follow these patients up. And then patients on surveillance. So many patients on cancer surveillance the responsibility falls within secondary care, and that's pretty much all patients on follow-up at the moment. But with the introduction of stratification of follow-up, we might find that we work in areas where some of this responsibility falls to us in primary care, and having systems in place that we can make sure that people who need an annual PSA, who need an endoscopy every 3 years or whatever the follow-up might be, that we've just got perhaps even a double safety net, so we're safety netting them in primary care as well as the responsibility falling in secondary care. I'm going to briefly mention the QoF-QI and the PCN-DES because safety netting is an explicit request mandating both of these requirements. And there's just a slight subtle difference between them. So the QoF-QI asks practices to ensure that they've got robust safety netting processes in place for people who are on a 2-week rule referral. For those that haven't been referred because they might be low risk but not no risk, or perhaps at the moment because patients have requested not to be referred because they've got concerns with attending secondary care health settings. And for everyone, some of us may have had patients that have been downgraded more recently because of the COVID pandemic. So we need to make sure that we've got systems in place to follow these people up to achieve the requirements of the QoF-QI. The PCN-DES is just slightly different. Again, it asks for robust safety netting processes. It again specifies people who have been sent on a 2-week rule, people who've been sent for direct access diagnostics, or for people with concerning symptoms that we might want to proactively follow them up. Now, there's no need to have separate systems, for these two things. We should have one system in place that incorporates all this. I'm now going to, in fact, maybe we'll just have a little pause. I'm just going to ask Zara if there are any questions in the chat box before I hand over to Sue, who's going to work through some South East London data. Zara, is there anything to cover at the moment?
No, none at the moment.
Thank you. I'm going to hand over to Sue for the next few slides and then we'll come back to myself. Thanks, Sue.
Thanks, Anthony. So good afternoon, everyone. My name's Sue McNulty. I'm the Facilitator Manager for Cancer Research UK for South and North West London. And I probably, my face is probably recognisable to quite a few of you because I was a facilitator in South East London until last year. So the first thing I just wanted to point out to you is it's not actually on our website, but if you click on this workbook, if you click on that when you get the slides, that will take you through to a kind of checklist workbook that Cancer Research UK has put together. And that can be quite a useful exercise to go through as your PCN or within your practice or both. So I would recommend that. And as I say, if you click on that, that will take you through to the workbook. Next slide, please. So I'm going to talk about the National Cancer Diagnosis Audit. The results have just come out for South East London Cancer Alliance. The slide that I'm showing you, the light blue is South East London Cancer Alliance, and the dark blue are the results from the other practices that participated in England. So we're not saying it's an England result, we're saying it's an England result for those practices that participated in the National Cancer Diagnosis Audit as a comparison. But it is a very rich data source for South East London. I'm delighted to say that we had an audit of 52% of patients diagnosed in 2018. Thanks again for all those practices who took part, giving their time to contributing to this. So we've got data on 3,300 patients. And as I say, we've got over half of the patients diagnosed in 2018. And what this slide is showing is that in South East London, 36% had safety netting recorded in those patient notes, which was slightly higher than the national comparison. For 30% of patients, it was not applicable. And for 20% of patients, it wasn't really clear if the patients had a safety netting recorded or not. And for 14% of patients in South East London, safety netting was not recorded. Next slide, please. But, where it gets interesting is this slide where we talk about, having gone back and done your kind of clinical detective and looking retrospectively for the audit, it's not been clear, what contribution that safety netting had. Now, that might be because, just routinely, you might not, necessarily to say to the patient, are you here today because I gave you a leaflet or because I asked you to. But it could also be some insight when you look at your audits further and have that discussion. How easy is it to read each other's notes and what you're putting on there, etc. So that might be a good conversation starter for you. There's also, I think, as Anthony has said, the safety netting, I think, is very, very topical at the moment because of COVID. So, I think the kind of one of the big outcomes of COVID will be that practices have perhaps, engaged with safety netting tools and advice and guidance and other ways of working that they may not have done previously. Next slide, please. This is a slide that's showing, the different places that delay can set in, and also, the different places that patients can be lost. And really, that first symptom through to treatment starting, there are multiple points where unfortunately, the system might not, perform as it should do. One of the insights that we've got at Cancer Research UK is we've just done a survey of 1,000 GPs across the UK. And one of the insights of that is that one of the groups that they're most concerned about is older patients at the moment not presenting. And I was speaking to a GP the other day and they put it very well. They said, it's about really trying to be that, not only keep that door open to patients to come back if they are concerned about their symptoms, but also looking at what systems where perhaps you're not doing, normal reviews as you would be still, how you can kind of become think beyond being a gatekeeper and a gate opener in terms of, making the most of those consultations with patients when you do speak to them. And bearing in mind as well that, this slide was produced pre-COVID, so you've now got, other things to come in there. There's telephone calls to factor in face-to-face, virtual consultations, etc. And also, new pathways. And our final slide today will be the links to the South East London Cancer Alliance bulletins, because particularly as we're going into the second wave, there may well be, changes to the pathways or updated information, etc. So part of safety netting is engaging with that and making sure, that within your practice, you're accessing those bulletins and sharing that information. Next slide, please. This slide, if you add it up, the percentages come way over 100% nationally and for South East London. So these are the different points where delay was thought to have happened according to those GPs who participated in the audit. I think what's quite interesting about this, and if I was a researcher, what I'd be asking for some research to do is, this is suggesting that patients have more than one delay in the system. And that again perhaps suggests something about the demographics of those patients who have a delay. Are they carers? Are they more elderly? Might they have, some kind of learning disability, which maybe has or hasn't been coded in their GP notes? So I think this is quite interesting. There's something, again, when you do look at your reports, maybe have a think about, looking a bit further into that. Next slide, please. Next slide, please. So I'm just going to talk about COVID-19. We've probably touched on some of this already, but the pandemic has significantly changed the way that GPs are working, and it does highlight the need for more robust safety netting. As we've already mentioned, there is more use of virtual consultations, both in primary care and with secondary care as well. And that, structured and explicit follow-up is more important. As we said, there are changes that have been made to some of the referral criteria, etc., which means that people might need to be monitored or followed up more in primary care. We've got new tests, we've got high risk fit. And again, that highlights the need for a clearer understanding of, what is going to happen next in terms of follow-up responsibilities. And there's also needing to understand that triage safety netting process in secondary care is imperative. So, when you're speaking to patients and making your 2-week wait referral, get them on board early about, what's going to happen next in terms of, their first initial consultation with the consultant is more likely to be on the telephone or in a virtual way. Next slide, please. So this was some safety netting guidance that Cancer Research UK put out in June. It's very timely as we go into the second wave to have another look at this. I'm not going to talk about every point of this, but, as ever, patient communication is really, really important. So there's 2 slides here. The first is on patient communication, and the second is on the safety netting processes in your practice. And what this slide does is it breaks down kind of 3 possible scenarios that you might have at the moment. So the first is you refer a patient on an urgent suspected pathway, nice and straightforward. The second is the patient is not referred, either due to their level of risk, or more likely at the moment is to be, as we come into the second wave, is to be the patient's concern about the COVID risk. And obviously that's a challenge for GPs as well. The final scenario is the patient has been downgraded. And just a reminder that the national guidance is clear that the downgrade in this scenario should only be happening with the consent of the primary care referring person. So just some things to highlight there on the patient communication. As I say, the patient information leaflet, the contact details of the patient, advising them when they were likely to hear from the hospital, and also what that kind of interaction, if it is more likely to be a telephone or virtual consultation, that the patient is aware of that. For the patient who is not referred, it's about coming to that joint decision, explaining the COVID v cancer risk, making sure the patient knows, to get in touch if their symptoms worsen. And again, keeping that door open, that if they do go away and, think through again the risks, etc., that they, definitely can change their mind. And then the final part is about the downgrading. As I say, again, do bear in mind that the safety netting is still, if the patient's symptoms worsen, they are to get in touch. Next slide, please. I'm not going to talk too much about this one, but this is a nice lead into the next part of the presentation, because here it is about document systems and reminders. Again, contact details, using the system, and bearing in mind that if you are, using your own diary entry system, etc., the current situation that we're in COVID, or even outside of COVID, can a colleague or someone else in the practice pick up your system and grapple with it and understand it? The most robust way of safety netting are the process-wise systems, as opposed to kind of individual. And really as well, just, safety netting has been quite a sort of organic process in primary care. It's got better as time has come on. And we are at the point now where, you can engage quite quickly with some of the software tools. But also just always recognising other new things that you might need to safety net as time goes on. So, for example, I was speaking to a GP the other day outside of London, and they're increasingly starting to use advice and guidance. So he was saying, I need to safety net that. I need to put myself a diary reminder if I haven't heard back from the consultant within a set date, that I need to pick that up and action that. Next slide, please. So I'm going to hand over back to Anthony now, who's going to talk about some of the individual systems you might want to explore and try out. Thank you.
Thanks, Sue. Just want to flag, there was a little message that came on the screen, I think from Shilpa, feeling that the slides weren't moving on, but just to flag, Sue, there were 2 slides then that Sue presented that almost look exactly the same on the screen, but they are 2 different slides. One is kind of more patient advice, and one is more primary care system advice. So they are 2 separate, they just look the same. You probably couldn't see that they'd flick from one to the other. And they are great information leaflets then. So please do, kind of when you get the slides, maybe spend just a few minutes having a read of those. So I'm just going to check with Zara if there's any questions. I don't think I've seen any more pop up, but just before we move on. Right, okay, good. So I'm just going to talk a little bit now about some of the IT systems you can use within primary care, and some of which I'm much more familiar with than others because of the primary care IT system I use in my practice. We have sent out this information previously through the South East London newsletter, and the links should all be on the South East London CCG website as well. But we will be sending out these slides, and you should be able to click through to the resources through these slides. But perhaps when we send the slides, Zara, we could maybe send a link to where the safety netting advice is on the website as well, if that's that's feasible.
Yeah, that's fine.
Great. So within EMIS, you can obviously just use diary entries and alerts yourself, if you just want to safety net for yourself. But there is a specific cancer safety netting tool that is inbuilt within EMIS and is available across the UK for anybody using EMIS Web. It was developed a couple of years ago by a GP called Afsana Bhuiyan, who was a Macmillan-funded GP as part of a Macmillan program we had at UCLH. And she was very passionate about the use of IT systems to safety net patients, specifically around cancer. And so she developed this tool. So there are 4 elements to the tool. It's an automated tool, so it's you just need to activate it in your practice. And you'll see there's various links here that you can use to probably maybe just to give to whoever leads an IT in your practice to make sure that it's set up within the practice. There's a YouTube guide so you're clear how to use it. And my advice would be that if this is set up in your practice or across your PCN, then perhaps you might want to have an education session for everybody who might be using it, both clinical and non-clinical, that everybody's clear on how it works. So there are 4 different pages you can use on this tool. The first is for 2-week rule referrals, and some people might choose only to use it for 2-week rule referrals. However, going forward with the QoFQI and the DARES, the other elements to this tool are invaluable. So once you go into this, the 2-week rule page, you'll see all the different 2-week rule referrals you could do. You just click that one's been done, add a diary entry, and then the date you put in will form part of an automated search, which I'll just mention in a couple of minutes. You can choose whatever date you put in those diary entries. So again, you might choose as a practice to put in a diary entry for 2 or 3 weeks later to have given the patient a chance to have had the appointment and potentially, hopefully, some correspondence to come to the practice. There's also a page for direct access diagnostics. So this might be really useful for those patients who haven't been referred on the 2-week rule, but you are concerned about. You may have done some blood tests or a chest X-ray, an ultrasound, potentially a CT, and you want to make sure that the result is followed up. So you can click whatever diagnostic you've done, and again, choose a date to put in a diary entry, and that again will form part of an automated search. You can use it for vague symptoms as well. So we've talked a little bit about vague symptoms, and we're really lucky in South East London to have access to a really great vague symptom clinic. But for a lot of people, perhaps before we refer them to a clinic, we will monitor them in primary care for a while, many of which will get better, but some won't get better. And so you can use one of the pages in this, one of the tools to follow up patients with vague symptoms. You can put in the symptom you're following up. You might have decided and hopefully agreed explicitly a timescale with the patient, and then you can put a diary entry in for that timescale, and again, it will form part of an automated search. You can put free text in, so if you're not there and somebody else is following up, they'll understand why you've made that diary entry. And then, as I said, some practices may choose to follow people to use safety netting systems to make sure that people who are due to have planned investigations, perhaps because of other serious conditions, pre-cancer conditions or a previous cancer, and we can make sure that they have all the appropriate investigations they need, so such as PSA or endoscopy or mammography potentially. So there are links in there. If you just go back a second, thanks, Lara. So there is an automated search as part of this toolkit, and you can decide how often you want that search to run. You can decide, you want it to run on every Monday or the first Monday every month. You decide as a practice team how often you want that automated search to run, and then you'll have hopefully one or two members of staff that will look at the results of that search. They don't have to run it because it will run automatically, but they can look at the results of that search and then decide what action needs to be taken. And once people have been seen, once tests have been done and they've been followed up, that diary entry can be completed. Thanks, Sarah. So there is also a system in Vision that you can use for proactive follow-up as well. I don't use Vision, so I'm not as familiar with this tool, but it runs in a similar way, but it doesn't have automated searches. But there is a PDF there that you can link to, and Vision have advice on how to safety net on their website. So if we do have any Vision users on the webinar, I'd encourage you, when you get the slides through, click through to the links, the Vision help desk, where you'll get advice on how you can use diary. It works in the same way it works on a diary entry system, and you can allocate it to different members of staff. But I'm not as familiar with this tool, so I'd encourage you to use the links to and work with whoever leads on IT in your practice or your PCN to implement the system there. Thank you. I think one of our CCGs now in South East London has See the Signs, which is a referral, an early diagnosis support and referral management tool that is integrated within primary care IT systems. And that has a specific safety netting page and a safety netting dashboard. Hopefully you've all been taught how to use that. I think it's in Bexley, sorry, where this is available to GPs. If not, if you contact See the Signs, and they'll be able to explain how to use that. Or if you contact Zara at the South East London Cancer Alliance as well, we'll be able to signpost you to how to use the See the Signs safety net element. But hopefully you've had that education as part of implementation of See the Signs in your CCG. So this is just a page to, as a bit of a reminder of other resources we have within South East London to support you around cancer at the moment. So we have the South East London CCG webpage, where we put all of the resources we're developing for cancer. We have the weekly bulletin that goes out. So if you're not receiving that bulletin in your practice, please use the email address there, and we can make sure that you're added to the list to receive the weekly bulletin. Remember that there are a myriad of patient information leaflets that we have available to you that you should use as part of your safety netting, and there's a link there specifically to the FIT ones. We are finding that we're still getting a certain number of FIT tests that aren't being used in the right port or don't have the right information and date on. And so it's really important that you do give a patient the patient information leaflet so that they know how to use the kit. And that is available in multiple languages and should be available very easily through TQuest with just 1 or 2 clicks. And it should come up automatically when you request the kit. So make sure you hand in those to patients. And then this webinar is part of a series of webinars. Hopefully if you're here, you're already aware of that. But if not, please do go and have a look at all the webinars that we've got coming up. We've got one on diagnostics. We have one on learning event analysis, significant event analysis coming up soon. And then in the new year, we have some on personalised care for cancer within primary care as well. So make sure you familiarise yourself and sign up for those upcoming webinars. So I don't know if there are any questions for myself or for Zara. If you have any, please just put them in the chat. If not, or you come up with any, obviously after the webinar today, please feel free to email us with any queries or questions that you have, and we will endeavour to get back to you on them.
There aren't any questions at the moment, so okay. I think if we don't get any, let's just sign off early.
Okay. People
can get a cup of tea.
Yeah. So thanks everybody for joining. Sorry, you go ahead, Zara.
No, I was just going to say exactly the same thing. But just to recap, I will send round a link where you can access all of the slides for this webinar, but also for others as well. We've got a chat. How do you safety net for patients that are given a dummy appointment?
Right, so I guess this, in theory, shouldn't be happening for urgent suspected cancer referrals. And I guess my only advice would be that you could use a diary entry and choose a time period. So maybe choose 2 or 3 weeks to see if that patient, and ask somebody in admin to then check on the ERS system if the patient has been given an appointment. There is no page within any of the IT tools that specifically looks at that, but as I said, they're all based on diary entries. So if you just put a diary entry in, obviously then and follow that up as you would follow up your normal diary entries, and obviously hopefully somebody from admin could then just go on the ERS system and see if the patient's been given an appointment.
Thank you. Hopefully that answers your question, Penelope.
I think
but
Penelope then followed up saying that perhaps this is happening all the time.
Yeah.
If you're getting a lot of patients that are given dummy appointments for urgent suspected cancer referrals, that's perhaps something you might want to feed back to your CCG or to ourselves at the Alliance. Obviously, some of the pathways, well, particularly the lower GI pathway, has a telephone triage, so it may come up as a telephone triage appointment, which is slightly different than a dummy appointment, but patients shouldn't really be getting dummy appointments for urgent suspected cancer referrals. So perhaps you might want to feed that back to us directly, Penelope, and we can look into that.
Thank you, Anthony. I don't mind a telephone triage, but they happen all the time. Penelope, what I'll do is I'll send you my email address and then you can send us an email about it. I think that's probably the best way forward. Okay, so thank you everyone. As I was saying, I will send round a link to the slides, and that link will also include all of our other slides from the other webinars that have taken place. The link to the evaluation form will be shared with you after this webinar has finished. So we ask that you please complete that, and then you'll receive a certificate of attendance as well. So I'd like to thank our panelists. That was a really great, thank you for the presentation and the webinars, for the webinar today, and have a nice afternoon. Thanks, guys.